afternoon and welcome to the ENT and Critical Care session of the RCSLT conference. My name is Dr. Gemma Clooney and it is my pleasure to be chairing this session. There's a few different little housekeeping things that I just have to remind all of you of. We don't have a planned live Q&A at the end of this session. So if you have any questions, please could you just pop them in the chat? The tabs on the right hand side. The questions are visible after the session, so presenters and the chair can kind of answer as we either go along or afterwards. But that's just to remind you of that. We've got a chat function as well to share any comments and feedback, but just remember that these are being monitored, so please be kind and respectful when you're sharing your comments. We're recording all the sessions and they will be available in the video section of the platform after the live event has taken place and will remain on the platform for 6 months after the conference. And please leave some feedback for speakers and event organisers. It's the only way in which you can kind of improve future events. And you'll also earn points. And just a last thing, at the end of the session, there's a secret code. If you make a note of it, there's a challenge hub that you can go to, enter the code and move yourself up the leaderboard. Anyway, that is enough from me. It is my absolute pleasure to introduce Dr. Anna White, who is going to be talking to us about the pre and post-operative voice therapy for benign vocal fold lesions, the PAPOV feasibility trial. Over to you, Anna.
Thank you very much, Gemma. Firstly, I just need to say apologies. I am in a bit of a viral centre at the moment, so apologies for my voice. It feels, not sure whether it's fitting or not fitting that I sound like this today, but I will do my best. Okay, so yes, I'm going to talk about the PAPOV feasibility trial. And first of all, I'd just like to acknowledge that the work shared in this presentation today is only possible thanks to the involvement of many other people. I'm very grateful to all of those who've contributed in so many different ways. And thank you also to the Royal College for giving me the opportunity to speak today. So why did we need to think about developing an intervention for patients with benign vocal fold lesions? Well, management of benign vocal fold lesions is variable. Some patients will have voice therapy alone, some surgery, some pharmacological management, or a combination of these approaches. And there was a need for improved understanding regarding best practice, consistency in clinical care, and an improved evidence base for this population. These are the words of Dan and Caroline, who are two of my patient representatives. Their influence and voices, amongst others, have been really, really important in understanding the patient's view around the role of pre- and post-operative voice therapy. Dan said, for example, it was a crucial aspect of helping me to start to recover mentally and physically. And one of the most helpful things was a speech and language therapist explaining how it all worked and what probably caused my lesion and how we could work together to make sure that that didn't happen again. Another quote by Caroline emphasises the importance of multidisciplinary team working. She says, "I can't emphasise enough. They knew that it wasn't like, oh, there's a lesion, let's take it off, but they all worked together." And in addition to our patients' views, evidence from the literature, although having some flaws and overgeneralizations, does support SLT involvement in patients undergoing surgery. A couple of studies published a number of years ago concluded that pre- and post-operative voice therapy could improve both acoustic and quality of life outcomes in patients with benign vocal fold lesions. In the clinical practice guidelines for hoarseness, the European Laryngological Society and the Royal College all advocate for patients to receive voice therapy in conjunction with surgery. A systematic review that I did a few years ago now showed high patient satisfaction associated with high levels of pre-operative voice therapy sessions. But an ongoing problem was understanding what the intervention should look like, and really if one could be specified to the level of detail required in order to develop the evidence base. So this slide summarises the different pieces of intervention development work that has gone into developing the PAPOV intervention and achieving this consensus. The intervention has been developed by patients and a range of stakeholders, which includes speech and language therapists from all over the world. So I'm going to run briefly through what the intervention looks like before sharing how feasibility testing has advanced our knowledge. So the Papov intervention is based on treatment theory, and it's based using the Rehabilitation Treatment Specification System, or the RTSS. So treatment theory involves considering an intervention in terms of its target, so what needs to change, the ingredients, what can I do to affect this change, and then by understanding those two elements, we begin to understand the mechanism of action. How might this change occur? So the Papov intervention has 7 essential components, and each component has a target and either one or more ingredients. By describing it in this way, it helps us to be more explicit about what we're actively doing in therapy and helps to understand how the intervention might affect change. So this is a summary of each component, but in the manual and the full specification, we go into a lot more detail about each of the ingredients, how they're delivered and how they are monitored. Each of these essential components is delivered to the patient at some point in their treatment, with flexibility as to when and how long clinicians should spend on each component. And then there are 4 additional components. These are introduced at the discretion of the therapist if they feel they would be beneficial for an individual patient based on that patient's existing skill, vocal presentation, and the goals for their voice. So let's now think about the feasibility trial. How do we test this intervention? Well, in January 2023, we opened a non-randomized feasibility trial with an embedded process evaluation in Nottingham. And then from March of that year, we opened in Lewisham. Feasibility outcomes included recruitment, attrition, and completion of outcomes, while the process evaluation looked in greater detail at treatment fidelity, adherence, and acceptability. The trial was open until November last year. And during the trial, we recruited 41 patients who had a clinical diagnosis of a benign vocal fold lesion confirmed by stroboscopy. All of these patients have been consented for surgery based on a discussion between the multidisciplinary team and the patient. Once consented, participants received the Papov intervention before and after phonosurgery. Data was collected at baseline and then at 3 and 6 months post-operatively. Now, a proportion of the patients in the trial experienced a complete lesion resolution during their pre-operative voice therapy. If they were happy to remain in the trial, their outcomes were still collected, but at 3 and 6 months from the decision not to operate. Participants were offered a minimum of 2 pre-operative voice therapy sessions and post-operative voice therapy as required. And this was delivered by 4 specialist voice therapists who had been trained in the Papov intervention. Multidimensional outcomes were collected, including a range of clinical outcomes and health economic outcomes. Data were also collected on intervention fidelity, adherence, and acceptability through clinical notes, video recordings, questionnaires, and interviews. So what did we find? Sorry. The patients in the trial were predominantly female, non-smokers, non-drinkers, and had a broad age range from 26 to 74 years of age. The diagnosis at microlaryngoscopy is included, and you can see that we had a broad range of both mucosal and subepithelial lesions. The total number of lesions exceeds the number of patients because some patients have multiple lesions. The first feasibility outcome concerned the number of patients eligible as a proportion of those screened. Findings were similar in both sites, and overall the proportion of eligible patients was 44%. Of those eligible, the numbers recruited were quite different depending on the site, but overall recruitment was 76%. The second feasibility parameter looked at how much data was completed. This helped us to determine the most appropriate outcomes and the timings of these in a future effectiveness trial. This table shows the proportion completed at each time point for each of the outcomes. Completion rates were very good, especially for the patient-reported outcomes, and rates were slightly lower for voice recordings, and this was because participants were asked to use an app to record their voice and send in their data. A few participants struggled to do this. Patients received an average of 4 sessions of voice therapy in total, so this was not typically a prolonged intervention. It was stipulated that they should be offered a minimum of 2 preoperative voice therapy sessions, and this was achieved in 93% of the participants. Only 3 individuals received only 1 preoperative voice therapy session, and that was due to a DNA and short notice surgery dates. All participants who underwent surgery attended postoperative voice therapy. Clinician and participant discussion determined the number of those sessions, but that ranged from 1 to 6 sessions. This graph shows the mean length of sessions in time in minutes up, with the time in minutes up the side, and then the number of sessions across the bottom. The mean length was 37 minutes, with considerable variation over the course of treatment, and sessions were primarily delivered face-to-face. So intervention fidelity considers where the participants received the intervention as described. Fidelity was very good. 93% of participants received all 7 essential components of the PAPOV intervention, and this was based on an analysis of clinical notes and video recordings of sessions. The essential elements were mostly introduced within the preoperative voice therapy sessions and followed up as required postoperatively. As this is a feasibility trial, it's not powered to show statistically significant change over time, and this is not the primary purpose of the trial. However, it is useful to look at this data to understand the magnitude of change in order to plan sample sizes for future trials. When tested, all patient-reported and clinician-reported outcomes showed a statistically significant change before and after treatment, as shown in the yellow. Changes were seen between baseline and 3 months, and also baseline and 6 months. There was rarely further statistical change between 3 and 6 months. Other data related to health economics was captured, namely a disease-specific quality of life outcome, the voice-related quality of life questionnaire, and a generic health status quality of life scale, in this case, the EQ5D5L. This shows statistically significant changes both in the voice-related quality of life and in the EQ5D5L scales before and after treatment. There was also a significant change in the pain subscale, which is interesting. There's a lack of data in the voice literature relating to health states, such as the EQ5D5L, but these measures do help us to gather data to understand things such as QALYs or quality of life years, which are important when we're considering whether the treatments are worth funding from an economic point of view. So we were able to calculate the cost of the intervention on average by looking at the cost of training and the cost of delivering the PAPOV intervention for different bands of therapists. And you can see, compared to the cost of surgery, PAPOV costs are low and emphasize the importance of getting in preoperatively, as it appears that even when the surgeon, speech therapist, and patient all feel like surgery is going to be required, a proportion of these lesions will resolve. So clinicians were also interviewed, as were the patient participants, and all 4 clinicians involved in delivering the intervention were interviewed. Interviews were undertaken by an experienced clinical academic not known to the clinicians, and that was in order to improve the chance of the clinicians feeling able to talk freely about their experiences. 4 themes were identified in these interviews: intervention content, perceived patient benefit, influences on the clinician, and impact on service delivery. So clinicians talked positively about the use of the RTSS voice to describe the PAPOV intervention. The framework, although they weren't familiar to it, was very valuable to them, and all valued the structured approach to the intervention. Clinicians felt they delivered a patient-centered, flexible intervention, which supported the patient from diagnosis through to discharge. All recounted instances of positive feedback from patients, both regarding their improved psychological status, as well as their increased knowledge and skills. And being involved in the PAPOV trial impacted clinicians differently depending on their level of experience. 2 clinicians discussed a significant increase in their knowledge and skills to work with this patient population, and this in turn positively impacted their confidence. The others found the intervention delivery confirmatory, and it added a more robust structure and prompted them to reflect on the rationale behind their decision-making. Clinicians did report some challenges related to service delivery, Voice therapy capacity was limited, and at some point, all clinicians found it difficult to see trial patients in a timely manner. I also interviewed 16 participants involved in the trial. Interviews were done at the 6-month time point, and participants were asked about their experience of being involved in a trial to understand both trial processes and acceptability. And then they were asked about the acceptability of the PAPOV intervention, and in particular, the barriers and facilitators of undertaking the voice therapy intervention. Participants described many factors that influenced how easy or hard it was to follow the advice, recommendations, and exercises involved in the PAPOV intervention. 3 themes were identified: capability, opportunities, motivation, aligning with behaviour change theory and the COMBI model. And then an overarching theme of support of others fed into and influenced all the other themes. So how does this impact clinicians now? Well, we have a described intervention that is feasible to deliver in the NHS. Furthermore, it was found to be acceptable to patients and clinicians in the trial. Training was well received with good fidelity after only a short training session. However, it is important to consider that ongoing mentoring and support are likely to be important in order to maintain that fidelity. It's also really important to remember that although preliminary outcomes are favourable, effectiveness has not been proven, and this needs ongoing research. So speech and language therapists are encouraged to initiate discussions regarding patient pathways, encourage referrals to their service early for patients who are consented to microlaryngoscopy, and be really mindful of the potential that pre-op work may actually negate the need for surgery. So finally, in terms of where next with research, the next steps could involve clinical and cost effectiveness testing. We want to have a further understanding regarding any modifications and tailorings for different lesion types. And it would also be interesting as a next step to consider the application of the PAPOV intervention with some modifications to other populations such as early laryngeal cancers and paediatric voice. Once again, apologies for the voice and the slight inspiratory stridor that I seem to be developing. I am fine. And I'll hand back to Gemma.
Yeah, please rest your voice now, Anna. But thank you so much. That was a fantastic presentation, and I'm sure that the audience really enjoyed it. We're now moving on to a presentation entitled Enhancing MDT Support for Non-Verbal Communication in Critical Care, a Service Development Project. And we've got 3 people who I can now see, which is great. Becky Sawyer, Esther Van Hove, I'm really sorry if I pronounced that incorrectly, and Megan Croker. So over to you for this section.
Hi everyone, my name's Meg, this is Esther and Becky. We all work at King's College Hospital in the critical care team. Today we're going to be presenting on a service development project that we completed around enhancing MDT support for non-verbal communication in critical care. The ICU shift towards earlier sedation weaning is well supported by evidence and guidelines, improving medical and rehabilitation outcomes. However, it creates new communication challenges. Intubated patients that are awake, or tracheostomized patients with the cuff inflated, may be aware of their surroundings but are unable to speak. This creates a cohort unable to participate in their own care, decision-making, or rehabilitation. As highlighted by GPICS, this can lead to frustration, anxiety, psychosocial impact, and risks decision-making being completed without patient consent. An earlier service improvement project examined the benefits of early SLT intervention for non-verbal communication for intubated patients. This project represents a second PDSA cycle. Recognizing the limitations of relying solely on SLT for non-verbal communication support, we aim to strengthen the nursing-led non-verbal communication support at King's. Our criteria for who requires non-verbal communication support is being intubated or tracheostomized with the cuff up, GCS 10 or 11 for consistently at least 4 hours. Within this, their GCS M score must be 6 following commands, and ideally they're attempting to communicate. For context, I will summarise what our SLT-led non-verbal communication assessment entails. First, we establish what the patient is already doing to communicate, and ideally lead with this to guide the next steps in a dynamic assessment. Next, we look at if the patient has a means of communicating yes and no. If this is not obvious, we aim to establish this through following different commands, being mindful that this can add increased cognitive demand. Then we assess the reliability of a yes-no response. Following this, we establish a method of communicating basic wants and needs, including pain. This includes using picture charts, gesture, etc., and considered access such as pointing or using partner-assisted scanning. If successful, we expand to novel messages using an alphabet chart, writing, or mouthing. Lastly, we aim to set up a list of frequently asked questions, ideally with the patient, but also with family or nurses to establish recurring topics. Following assessment, we support differential diagnosis with consideration of ICU delirium or reason for admission. We then hand over recommendations to family and staff. Ideally, this outlines how to successfully communicate with the patient. However, assessment and guidelines remain important if they reduce misinterpretation of communication. For example, guidelines may outline that a yes-no response is unreliable and needs of this patient should be anticipated. In this case, we prompt family to complete a "This is me" form to support the personalised anticipation of wants and needs. To summarise, the project aims to understand how NDT support of nonverbal communication can be further optimised on ICU.
So we had a multi-stage process for methodology. First, we reviewed the data we already collect for nonverbal communication patients. We currently collect the AAC OSTOMs on the use of AAC before and after an SLT assessment. We hypothesized that with an increased MDT awareness and confidence in nonverbal communication support, the pre-intervention score would increase after training. And next, we carried out 2 questionnaires with ICU nursing staff, the first of which looked at nurses' awareness about nonverbal communication and their confidence in using different AAC. And the second questionnaire looked at nurses' preferences for accessing AAC resources and training. And based on these findings from these questionnaires, we drafted what we call the Communication Support Pack. We then collected patient feedback on the pack via semi-structured interviews with 2 current ICU patients, as well as a focus group with 6 former ICU patients who attend our Critical Friends group, which we'll touch on later. Using this feedback, we finalized the Communication Support Pack, launched this on our ICUs, and provided training for our nurses. Following a period of implementation of the pack, we repeated the awareness and confidence questionnaires. We then conducted a data review of the pre-intervention AAC OSTOMs, as well as looking at some qualitative data. So in terms of co-production, it was crucial that we actually seek input from patients who have been reliant on nonverbal communication. At King's, we offer what's called the Critical Friends group, which is a forum where former ICU patients and families can meet to share experiences. And it was at this focus group, as well as speaking to our current patients, we use the point-based interview questions you'll see on the screen now to glean some information about what being intubated in a wake or tracheostomized with cuff up is like from the patient's perspective. From this, we gained really valuable insight into what's actually useful for this patient population, and we refined the communication support pack further. So here are the findings for the questionnaire looking at nursing preferences on AAC resource provision and training. We had 42 respondents across all 6 of our ICUs. As you can see here, the nursing staff demonstrated a strong preference for hard copies of the communication support pack rather than digital. And 95% of nurses had a preference for receiving guidelines on how to use the pack. And within this, there was a strong preference for written AAC guidelines. As for training, nursing staff demonstrated a preference for face-to-face training, particularly off the ward, and we also gleaned some interest for e-learning. So let's quickly go through the pack so you can get an idea of what we're referring to. So you can see we have kind of an intro and a contents page, some general tips for communication. We have some bits on assessing yes-no reliability. Yeah. We have an alphabet chart. And you can see here, not only do we include the AAC themselves, but also the written guidelines on how to use them, as per the feedback that we got from nurses in the access questionnaire. We received positive feedback from patients regarding the use of an FAQ list, because they identified it would be really frustrating and effortful to have to spell out their more common requests over and over again. We have the guidelines for those. And here we have our picture charts. We have feelings, wants and needs. You can see here we made sure to include pain relief, we'll touch on in a bit. And that's the pain page. So this is something we spent some time thinking about. We know that from the ICU A to F bundle that pain management is a key factor in reducing delirium, which is commonly seen on ICU. However, we know that patients are not always able to communicate this easily, especially if reliant on nonverbal communication. So feedback from our critical friends group gleaned that what was important for them was being able to say if they were in pain and where this pain was. So we simplified the pain page just to reflect this feedback. So following the preferences gleaned from our access questionnaire, we provided formal face-to-face training on the communication support back to nursing staff. This training involved education on the PAC itself, how to use the different AAC options, and we did some role playing with the nurses for them to practice, as well as troubleshooting any questions or concerns that came up. So what were the findings from the repeat awareness questionnaire? So this is the one looking at MDT awareness and confidence using nonverbal communication. We had 81 respondents, all of which were nursing staff. In terms of awareness, we saw a 43% increase in nurses naming any form of nonverbal communication support. But despite this, we did not see a significant change to confidence in using nonverbal communication support itself. We anticipate there's multiple factors that play into this, such as a high staff turnover, the PAC only having been out for a month at the point of the repeat questionnaire, as well as limitations to the questionnaire questions themselves.
So our results. When we repeated our data review, referrals for nonverbal communication support continued to come mainly from SLTs. We had expected to see more nursing-led referrals after the training, but this didn't happen. In many ways, this reflects our wider caseload, where most patients are identified during SLT screening. It seemed that our visibility and routine ward screening may have reduced the perceived need for nursing referrals. Staff may feel confident that SLTs will pick up communication needs independently, which is positive in terms of our awareness, but also might discourage proactive referrals. Looking at the OSTOM data, we didn't see any significant change in pre-intervention scores across activity, participation, and well-being, and this raised questions about whether the tool is sensitive enough, and I'll return on to that point later when discussing our project limitations. On the qualitative side, we saw more MDTs reference the PAC in conversation. Families were often aware of the PAC before meeting an SLT, which suggested that nurses were introducing it more informally, even if they weren't consistently recording or documenting this. The use of the PAC did vary, with more use with patients who could point or gesture independently, and less use when partner-assisted support was needed. Awareness of the PAC increased from 5% to nearly half of nursing staff after the intervention, which shows that the training and visibility really made a difference for us. We initially collected data on wait times to SLT intervention. However, as the project progressed, we recognised that documentation was inconsistent, and this was skewing our results. Because of this, we couldn't obtain accurate measures for wait times, and the metric was therefore not reanalysed. So what does this mean for practice? We have seen improved access to nonverbal communication support, with all 98 beds having access to a PAC and allowing early identification of needs and growing perceived confidence across the MDT. Patients who might otherwise struggle to express themselves are now able to access nonverbal communication support a lot quicker, and we have seen stronger interactions with patients, families, and staff. Ongoing training remains essential. Awareness is growing, but confidence and consistency still vary. We need to continue building this confidence across MDT, especially around partner-assisted communication and documentation, so that the PAC becomes embedded into routine practice. Importantly, what makes this work particularly meaningful is that the PAC was not only grounded by evidence-based practice, but co-produced with staff and patients. And that combination of research and lived experience has made both it clinically robust and genuinely relevant to everyday care. As with any project, it's important to acknowledge that there are limitations that have shaped both the process and the outcomes. And we came across several limitations during the evaluation, which may reflect the realities of working in a busy critical care setting. Staff turnover and shift changes meant that the number of questionnaire responses varied before and after the intervention, so it's unlikely we reached the same individuals at both points in time. While the feedback was valuable, we couldn't get a direct comparison. As mentioned earlier, the OSTOM outcome measures didn't seem sensitive sensitive enough to capture the changes we were seeing and feeling on the ground. Patients were engaging more, and families were interacting differently, and staff were using tools with greater confidence, but these shifts were not necessarily captured within the data. It is unclear whether this was due to the sensitivity of the tool, our anecdotal evidence, or whether the feedback is further work is needed to embed practice into change. It may well be a combination of both. Because SLTs complete the ratings themselves, anything undocumented introduced earlier in the day would not be reflected in the scores. Finally, awareness of the SLT role within in ICU continues to vary. Some teams are highly collaborative, while others may be less familiar with how we support communication. That affects referrals and engagement and is something we're working to improve. In conclusion, this project has shown that awareness of the communication support plan is growing and that is beginning to shape everyday practice. We know that cultural and behavioural change takes time, especially in large, high turnover teams, but the foundations are now in place. Patients, families and staff are starting to engage differently, and communication needs are coming into sharper focus. Communication scores, however, remain static with our data. This may reflect those perceived capability gaps or simply newness of the pack, and confidence may well improve with increased exposure and use over time. High nursing turnover continues to pose a challenge when it comes to training the whole workforce. We're now exploring different alternative approaches beyond mandatory training to make sure the resources reach more staff more consistently. We've learned a lot through this project, and I wanted to share some key reflections that have shaped our thinking going forward. Capturing qualitative impact remains difficult. We continue to prompt nurses to document nonverbal communication, even in small ways, to help build a clearer picture to support the MDT. Embedding a resource across multiple ICUs brings logistical challenges. Different units have different preferences of where the pack should be kept, and maintaining its position at bedside was not always straightforward. We have learned to be flexible and responsive to each team's needs. Finally, co-production has been a real strength. Although the draft and final versions of the pact were quite similar, the process reinforced that evidence base does reflect what patients value. It was important to hear their voices and keep them at the centre of our work, and that's what made the results not only clinically credible, but also meaningful for our patients. Finally, looking ahead, we want to focus on these three areas. We want to develop an e-learning module to make training more accessible and consistent. Secondly, we want to continue monitoring cultural change across units. And thirdly, we're going to maintain a slot in the mandatory training to help keep nonverbal communication on the agenda and support ongoing staff engagement. And then these are a few references that we had when we created our communication pack.
Thank you all very much. Thanks so much to Becky, to Esther and to Meg. And that was a fascinating presentation, really great example of kind of on the ground service developments that can make a difference clinically. So well done to all of you. Moving on now to Sam Briggs, who's going to talk to us about an SLT-led faster diagnosis standard 2-week wait clinics. Thank you, Sam.
Sorry, just sorting out my text slightly. But can I click through? Am I clicking through? Yeah. Okay, sorry everybody. Hello, my name's Sam Briggs. I'm a principal speech and language therapist at Queen Victoria Hospital in West Sussex. Today, I'll be sharing our experience of a new SLT-led faster diagnosis standard clinic for patients referred to the ENT team with a suspicion of cancer under this pathway. This was previously termed the 2-week wait pathway. For context or background information, QVH is a head and neck cancer surgical site. Patients are referred from across Kent, Surrey and Sussex, and the majority of our head and neck patients therefore are seen at other spoke sites during their pathway. When patients present with red flag symptoms for throat cancer, they're referred by GPs or dentists to ENT clinics for specialist assessment, and the target is then to be seen within 2 weeks of that referral. As with all cancer pathways, there is nice guidance about red flags and a list of symptoms that should trigger this specialist referral. Since the introduction of this pathway, head and neck referrals have seen a significant rise. The most common reason for referral via this pathway is hoarseness. This forms around 33% of those referrals. However, 97 to 98% of these patients with hoarseness alone do not have cancer. I am certainly not the first SLT to be presenting such data, and a number of our colleagues nationally have published work from pilots, which I believe started initially in Newcastle back in 2019, and these were based on successful models in Australia. But I will still touch on why this is thought to be needed. There is a predicted 33% increase in oropharyngeal cancer diagnoses by 2035. It's therefore crucial that we optimise ENT resources to support that dramatic increase in patients being referred and the associated treatment and management of these patients. Having the worried well use these appointment slots will mean that there are delays to those who do have a cancer. Over the past few years, the NHS is encouraging allied health professionals more than ever to extend their scope of practice. This can be seen in these quotes taken from the 2023 long-term plan. And having been identified as an underutilised resource within the NHS, this is where SLTs can play a vital role. So why speech therapists? Well, voice complaints are very common. 29% of the population experience them at some point. And in professional voice users, that figure jumps up to 82%. And in 2012, a study showed that benign dysphonia resulted in an annual work absence of 30%. SLTs with advanced skills can safely assess patients with a hoarse voice. This is very common practice. We also know that the most common diagnoses in ENT clinics for these referrals is not cancer, but benign conditions such as laryngopharyngeal reflux, muscle tension dysphonia, and globus. These are conditions that then usually become managed by SLTs. So can we now rule out what is becoming the ENT middleman in these cases? This will not only reduce waiting times to see the speech therapist initially, but it has been proven to result in lesser speech therapy follow-up appointments being required, with patients having accessed the most appropriate professionals straight away. Not only is this beneficial for the patient clinically, but clearly is also cost-effective with reduced staffing costs. The Australian work showed a 27% cost saving with the therapist-led model, but that doesn't account for the additional cost savings resulting from reduced duplicate referrals and reduced appointments. Speech and language therapists have so many skills already that allow for this transition. We know how to take a thorough case history about their voice. We're experienced in the perceptual evaluation of the voice, and we'll already be doing detailed patient examinations. More and more of us now have advanced skills in performing flexible nasendoscopy from the other work that we do. However, we do, of course, have to keep at the forefront of our thoughts that there is the potential that the person sitting in front of us does have cancer. We therefore do need upskilling in the focused case evaluation required for cancer screening, training in comprehensive neck palpation, and training around oral and pharyngolaryngeal examination, in which we're now scrutinising anatomy rather than assessing their function. I will come on to talk about how other hospitals are also using this speech and language therapy-led approach, but of course each of us might have gone about this in slightly different ways. So how we did it here, as I mentioned at the start, I'm a principal speech therapist, so I'm working as a band 8A. I have been competent as a level 3 scoping clinician for over 5 years, and I've worked in head and neck cancer for 13. At QVH, due to close working relationships and small teams, we simply started with observation of the ENT clinics. We then switched this to the ENT observing or supervising the speech therapist, and then we ran independent SLT-led clinics alongside the ENT consultant clinic in parallel. Only patients with a hoarse voice alone were initially booked into the speech therapy clinics. As well as the clinical development, I worked closely with managers around the practicalities, how many appointments, how long they each were, safe documentation, and nursing support for the clinics. Funding was agreed from the Sussex and Surrey Cancer Alliance for 2 years, and we also developed a standard operating policy for within our hospital. I then also undertook additional training to allow me to request imaging that speech therapists wouldn't usually. And of course, I had regular discussions with those involved to review how it was working or how it could adapt. The clinic was set up to have 3 new patient slots per week, each were 30 minutes. This was slightly longer than an ENT equivalent of 20 minutes whilst I was new to it. We are based next door to the ENT consultant or fellow and have either healthcare assistant or speech therapy assistant support. The consultant will join the session if requested and reviews all nose endoscopy images that have been recorded after the clinic. So we started the SLT-led clinics in September 23. I have since seen 63 patients in 23-24 and 17 in 24-25. This is thought to be reflective of a change in the ENT staffing establishment. And as I mentioned at the start, we know that the majority of patients who go on to need surgery here actually are seen in other hospitals initially. As predicted, most patients were taken off of the cancer pathway, and common diagnoses were reflux, muscle tension, dysphonia, and other benign pathology. There have been no adverse events. Nearly half were discharged altogether, but as you can see, of those needing some form of follow-up, nearly half of those actually needed a speech therapist and not further ENT support. As with any service, we've made adaptations since the inauguration. There is strong evidence that with additional symptoms comes a higher risk of cancer. For example, hoarse voice alone, 2 to 3% receive a cancer diagnosis, versus 6% if they are hoarse and dysphagic. We've therefore been cautious about increasing the inclusion criteria for SLT clinics, but felt that the addition of dysphagia, adynophagia, and other persistent throat symptoms was safe. The other red flag symptoms listed on the right here will not be booked into a speech therapy-led clinic. We've also added in some follow-up slots and have had discussions about the possibility of some laryngeal cancer surveillance slots, which would need separate governance surrounding this. We have talked about the need for more speech therapy slots, which hasn't been needed, and whether or not the ENT consultant clinic needs to definitely be running in parallel, for which it is still deemed necessary as our RCSLT provided indemnity insurance currently does not include this work as we are professionally deemed non-diagnosticians. It was therefore deemed essential so as to also be able to give the patient feedback immediately in the clinic. The anticipation was that the length of appointment would be shortened to match the 20-minute ENT slot. However, we have in fact kept this as a longer appointment so that the benefits of seeing a speech therapist straight away can be gained. This additional time allows me to undertake a more thorough functional assessment and give some therapeutic advice that they previously wouldn't have had at this first appointment. Leaving with some practical advice around how to help their voice and swallowing difficulties is undoubtedly a bonus. As I mentioned, other centres in the country have been undertaking similar projects, and pleasingly, many of us have been discussing this work, how we've approached it, how we see it moving, how we see it working moving forward, and what we collectively think are important considerations for this type of work. The group have collected some data around this. You can see here that there were thought to be 7 trusts who have implemented this type of work or at least piloting it. The inclusion criteria within those hospitals does vary hugely, as is seen here. So as I mentioned, QVH, we had set criteria of what we would include and not include, and you can see that there's big variation in this slide. We've also used this forum to discuss what we as a group should focus on collectively. We can use the forum to support each other clinically. We can consider if more formal competencies might be beneficial for others. Think about if our data could be uniform to provide a more meaningful, bigger picture. and how we might need to have some discussions with the RCSLT moving forward specifically about this type of work. Those of us in the forum are also aware that more services might be doing this work and we just don't know about it. If so, please do complete this questionnaire, as this gave the data that I just presented. And you are, of course, very welcome to join these meetings and help shape the agenda moving forwards. There is growing interest nationally, and perhaps there'll be more following this talk, and we're, of course, keen to connect with others doing similar work. I would also like to take a moment to thank the others in this group for letting me share this work that I can't take credit for. So the key messages are that we know that the utilisation of our current NHS workforce needs to be optimised. This isn't about replacing doctors, it's about using our unique skill set to improve patient access and efficiency. We can offer adjuncts to these first appointments if cancer's been ruled out, such as providing voice therapy there and then from day one, or undertaking FEES assessments during the otherwise anatomical assessment with a scope. It does, of course, carry an increased burden of responsibility, and this cannot be overlooked. It's imperative that we have strong governance structures in place to support our work, and I'm sure everyone in the audience would agree that recognition and support systems for these extended roles is essential. I've included a few relevant references for this talk, but thank you very much for listening, and I am happy to answer any questions that have been submitted today later on, or I'm happy to be contacted separately.
Thank you very much, Sam. That was another excellent talk and a really great overview of, I think, a really exciting development for our profession, actually. And hopefully there'll be much more work to come. We have 5 minutes left in this session, and there haven't been any questions submitted. I do have plenty of questions for all of you, and I'm just trying to work out who to pick on. But maybe, Sam, because you're there, one of my questions for you, it relates to how many patients do you think, because you've been able to see them as kind of first point of contact and have been able to give them that advice and potentially some therapeutic strategies to go away with, haven't needed follow-up? So you've kind of almost been able to one-stop shop them.
Yeah, it's a really good point that I didn't really touch on. I don't have numbers. I'd have to look at that, but I probably could. But I do think there are quite a few that actually they've just, well, firstly, obviously been reassured by a non-cancer diagnosis, which they would have had from ENT anyway. But also just having some advice that they can put in place. I did usually arrange follow-up, but it could just be by means of a phone call, and actually then at that point they often were saying, yes, that's fixed it, thank you very much. So I think it would be interesting data to collect for sure.
Yeah, because I think that's a really key aspect of those clinics, that we kind of need to demonstrate that we're essentially reducing the burden on hospital services potentially. Because we have time, I don't know if Becky, Esther and Meg, are you still there? I'm hoping that you are.
Still here.
Great. I have a question for you about your critical friend group, which I thought was a lovely way of describing the kind of patient involvement. How were they, or were they remunerated? Was there any kind of, how does that work? Because obviously it wasn't research, so I'm presuming you didn't kind of have funding to be able to pay for their time. How does that work at King's?
It's a voluntary group. Patients attend to kind of get support from each other and kind of support from different professionals, and across kind of AHPs and other professionals across the hospital, we kind of take it in turns to attend that group. So we did a lot of our kind of questionnaires within our kind of usual slot within the critical friends group. So that it's voluntary.
Lovely. No, that's great. That's really helpful. Thank you. And Anna, I'm reluctant to ask you because of your voice, but just because I wanted to understand, with your qualitative interviews with the patients, when you mapped to the COM-B model, is that because you analysed the data deductively in order to map in that way, or was it something that kind of happened because you looked at it inductively and realised that you could put it to that framework?
We mapped it deductively. And then we thought, is this going to be sufficient? Is this going to be enough?
Mhm.
And so in the end, we found. and it's
So
just-
sorry, Anna.
That's okay. Basically, yes, we used a deductive framework and then thought, is this anything else?
You definitely need some voice therapy.
I know. I do some lip trills.
Yeah, bless you. Oh, thank you so much. Well, thank you to all of you for such fantastic presentations. I think they really demonstrate the breadth of work that is going on in ENT and critical care SLT. And I, for one, am very excited to see what the future holds for all of your projects, actually. So hopefully at the next conference, we can hear updates. But given that I think we haven't got any questions in the chat, I will take the opportunity to close the session a little bit early to give people a chance to have a break before the next one. Thank you all very much.